feedback from you and from the external people. So the program today features a person that I've had the pleasure to not exactly work directly with, but work alongside and watch for a long period of time. When I was at the VA, I met this young psychiatry person. I was introduced by Charlie Marmer, then the head of psychiatry, who has a long history of working in global settings with traumatic situations. And he had a young person, Susan Meffert, who was interested and had already done work. I think at the time you were working with the Darfur refugees, women who had experienced violence from that crisis who were living in Egypt, but also has since worked in the Sichuan earthquake, kind of the post-traumatic stress experienced by the people there, including many people who lost their children in schools. And Susan has also worked in Africa, I know in Zimbabwe, but also now with Craig Cohen's FACES program in Kisumu, Kenya. And she's great. She's an assistant professor in the Department of Psychiatry here, but also a proud affiliate in the Global Health affiliate program. And we look forward to hearing your talk today. Susan, welcome.
Well, thank you very much. I don't know if I need this or not. I think that sound is probably okay. Yeah? Okay. Well, thank you so much for having me. I came to UCSF back in 2003 as an intern in psychiatry, and as Paul said, was lucky to meet him when I was in my residency in the research track. And Paul is the one who got me interested in HIV among women and the trauma needs there. So I joined the faculty with the help of Global Health Sciences Burke grant back in 2009. So been lucky to be part of Global Health Sciences for a long, long time, and seen its growth and the growth of its training programs, and that's been spectacular to see. So I'll be talking with you today about little background in global mental health, since it can be a field that not as many people know about as we would like. And then I'll tell you a little bit about what I'm doing now in Kenya. So first of all, I'm sure you're all very familiar with the DALYs, the Disability Adjusted Life Years. These were first introduced, if you don't recall, for those of you who are younger than I am, in the 1990s, and they were revolutionary for the field of global mental health. The reason is that the DALYs were the first measure of disability as opposed to mortality. So prior to the DALYs, much of global health was reported in terms of life expectancy, live birth rates, etc. The DALYs were the first widely used measures of disability. And surprising even to mental health professionals was the fact that they revealed a huge burden of mental disorders. So mental disorders, as you know, implicit in what I said there, is they cause disability. They don't often cause a great deal of shortened lifespan compared to things like malaria, diarrhea, etc. So where you will see them is not in the years of life lost, but in the years of life spent disabled. So that aspect of the DALYs is what really allowed the global mental health burden to shine through. And it's shown through quite brilliantly in a huge way. They're now known to be, just one mental disorder, depression, is known to be the leading global cause of YLDs. That's just one. That's the leading mental disorder worldwide, and it's now the leading cause of all YLDs in the world. This is from Global Burden of Disease Study in 2013. A couple of things I want to point out. First, this is global, and you see that it's about 161 million YLDs. And the second is the shape of the curve. So the shape looks, it's that light-ish purple, medium purple. It looks a bit like a mountain, right? It's sort of a normal-ish distribution. Compare that to a lot of the other curves that you see up there, which look more like a cliff. They look skewed to the right, to use more scientific terminology. So the interesting thing about mental disorders, and one of the reasons it causes such bad disability, is that it strikes young adults, and then it lasts their whole life, typically, if it's not treated. That means it can cause great disability, and I'll tell you more about that in a moment. So this is global, about 161 million. If we take out high income, we just look at low income countries, we have 128 million. So that tells you that the vast, vast majority of our global burden of mental disorders are in low and middle income countries. So why is that? One of the primary reasons is what the WHO calls the mental health treatment gap. Not only is the population larger in low and middle income countries, but 75% of people with any serious mental disorder never receive treatment in low and middle income countries. Not any treatment. That's not just subpar treatment, it's any treatment. We're going to be talking quite a bit about that. So this looks like a big problem, right? What have we done about this in the past? What has the global health community done about mental health? As I mentioned, the starting point was the 1990 Global Burden of Disease study, which first revealed this big burden of mental disorders in low and middle income countries. And then 11 years went by, nothing happened. Another Global Burden of Disease study, 2001, basically the same thing, a huge burden of mental disorders. Finally, The Lancet launched its call to action in 2007, said, hey guys, look, we have this huge burden of mental disorders in low and middle income countries. No one's doing anything about it. Let's do something. 2008, that statistic that is sadly still true that I just mentioned, 75%, 10 years later, still are not receiving any treatment at all in low and middle income countries. And then in 2009, a nice publication in PLOS Medicine about global mental health and the need to address it. 2010, the first funding from Canada, Grand Challenges, with Peter Singer, who's coming later in the spring. And also in 2010, the repeat of the global burden of disease. Now, mental disorders were the leading cause of YLDs, and they were increased by almost 38% from 1990. 2010 also marked the NIMH, National Institutes of Mental Health, Global Mental Health Grand Challenges article. That was through Pamela Collins. It was a really nice publication. I think that was Nature, if I recall correctly. And then 2011, the first RFA, research funding announcement for collaborative hubs from the National Institutes of Mental Health. That means NIH was finally willing to put some money into this in 2011, about 20 years after the first revelation of the need. not to be too sarcastic there. 2011, Lancet issued yet another call to action. And then in 2011, this was a big year, we also had the World Economic Forum take note that mental illness will account for more than 50% of the global economic burden over the next 20 years. In 2012, WHO adopted these NCD targets, which did not include mental health, but were sort of implicitly pulled in at various times. And then 2013, the WHO issued a separate mental health action plan and the first K award. A K award is important because it's usually, if you're not aware of them, they're the first grants that young investigators get, which allow them to launch their career. So having a K award that's dedicated to global mental health is important because it signals to young investigators that there is money there to support their career in global mental health. So that was a nice thing that NIMH did. Not that you couldn't be funded by K awards generically, which is how we did it for my funding, but it's a good signal. Also in 2013, this final iteration, most recent iteration of the global burden of disease, now mental disorders are the primary driver of per person, one of the four primary drivers, I should say, of per person increase in YLDs. So that's a big deal. So what disorders exactly are we talking about here? Are they really exotic, hard to treat things? No, actually. These are the top 5 contributors to mental health DALYs. Almost half is due to depression, and another about 15% is due to anxiety. If you are a mental health practitioner in the U.S. or any other high-income country, depression and anxiety is your bread and butter. We've known how to treat it for about 40 years. We can treat it a million different ways. We're usually quite good at treating it. We can make it go into remission. We can do all kinds of different types of therapy, use many different combinations of medication, and we can almost always make a big, big dent, if not a complete remission happen. So I'll pull this up just for the skeptics because it often comes up. And this actually comes in part from the field of medical anthropology, Arthur Kleinman's work and others. There was a big question at one time, it probably peaked the debate at about 10 years ago, about whether or not using tools that we've developed, admittedly in Euro-America, to measure mental illnesses outside of Euro-America was a valid way to assess those disorders, i.e., is this big burden that we see in low and middle income countries of various mental disorders really reflecting true disease, or is it just a sort of an artifact of the measures that we're using and they don't actually have depression or these other disorders? So like I said, this debate is largely past at this point. I think these prevalence studies have been repeated many, many different ways using many different measures. And most people agree now that even if the stats aren't precisely what the GBD says, they are at least close enough that we can all agree we have a problem. However, just to take note here, when there are enough resources and personnel resources and funding to do the large validation studies that you have to do in order to cross-culturally validate a psychological measure, the results using that measure are typically very, very close to what we find when we use a standard measure. There hasn't been a big difference. True, we haven't done those massive resource-intensive studies in every subpopulation that we could, but I would argue ethically there may be some question as to whether or not that's where our resources should be spent anyway. Harvey Whiteford, who's the architect of some of the best epidemiology for global mental health, for the Global Burden of Disease study, has a nice even-handed statement on this in a recent publication. He admits, there is universalism involved with these measures. That's true. But at this point in time, at this the state of knowledge that we have now, the alternative would be simply to ignore mental disorders worldwide, and that doesn't seem like a viable alternative. And I'm happy to talk more about that. So why do we have this huge treatment gap? We've known, as I mentioned, for more than 4 decades how to treat depression and anxiety in high-income countries. And we've also known, believe it or not, for about 15 years how to adapt evidence-based treatments like short-term psychotherapies to be efficacious when applied by people without any advanced training in low and middle-income countries. That's been going on for about 15 years. We've been doing these T1 level studies, and we know it works. It works with CBT, IPT, works with NET, narrative exposure therapy, cognitive behavioral therapy, interpersonal psychotherapy, CPT, cognitive processing therapy. We know all of these things have efficacy, that's T1, in these low and middle income countries. And I'll come back to this issue. So if those moral and ethical arguments are not convincing, let's think about the economics. Like I said, this World Economic, startling statistic from the World Economic Forum, mental disorders will account for more than 50% of the global economic burden over the next 20 years from NCDs. The reason is, I alluded to, the timing of their impact in young adulthood, and also the large impact on productivity and medical costs. So taking an example from depression, this is a study by Beck et al., which looked at productivity. Productivity is here formally defined as a combination of absenteeism, meaning missing work, and presenteeism, meaning lower quantity of work produced at work, or amount of work produced at work. When you combine those two, they call it the productivity, and that's on the y-axis. So if you have a PHQ-9 score, which is a measure of depression that's relatively low, 7 to 9, correlates with mild depression, you have a productivity loss of about 30%. So if you have mild depression, you're producing about 30% less than you would if you did not have depression. If you have moderate or severe depression, you're producing about 50% less of what you would. So you combine that with a decreased productivity from an employee with the right-hand column, increased cost. So you may have heard depression has these high correlations with other physical health problems. Cardiovascular disease has been in the press a lot, but also substance abuse. A lot of people do self-treatment with alcohol. They can't sleep. They have PTSD, so they drink and then they get addicted. or with food. Some people eat when they feel sad or they feel down and they gain weight. They can't exercise because they don't have energy. So, in fact, this rather amazing stat. We all know smoking, for example, is bad for you, but the health costs, physical health care costs associated with smoking are outpaced by the physical health care costs associated with depression, even if you take out the depression treatment. Does that make sense? So even if we subtract out the mental health care treatment, the physical health care costs associated with depression are higher than those that are associated with smoking. That's pretty remarkable. Of course, those are big population level studies, but it's an incredible statistic, I think, that doesn't get highlighted very much except in the economic literature, where companies are noticing this, obviously, on their bottom line, thinking that perhaps we should be treating this depression because it's making people's health care costs go up. So what research is needed? The question is more like, what is not needed? This is a map of the PIs and in some cases teams that are working on that have consistent programs of treatment research for common disorders among adults in low and middle income countries. So there's us out here at UCSF. There's a developing program in Washington with Jürgen. There is Hopkins, which has a number of PIs. There is Lena Verdelli at Columbia. And there is Teresa Betancourt is at Harvard, who works with adolescents. I didn't include her here. And then there is the London School team with Vikram Patel and others who have done a lot of work, at least tangentially related to specific treatment research and advocacy. And then a PI in Germany and a PI, two PIs in South Africa, Crickland specifically at Cape Town, and then a couple in Australia. And that's it for the people who are working on the largest leading cause, the largest cause of disability in the world. It's remarkable to me every time I think about this. So again, reiterating this, I hope you're starting to find it as galling as I do. We've known for 4 decades how to treat this stuff. We've known for about 15 years that we can do it in low and middle income countries. Why, as I should have mentioned on that prior slide, most of the work done by all of those teams has been T1 level work, meaning that they're going in and testing to see whether or not IPT, CBT, CPT, NET have efficacy in low resource settings compared with their performance in high income settings. Why are we repeating these studies for 15 years when we need to start scaling up and actually treating people, right? RCTs do not result in a scale up of care. You can do 1 million RCTs and never change population health. I'm sure you all are aware of that. So one reason, I think, is that we have not used good implementation models in global mental health. And also there are some particular needs for implementation models in global mental health. So this sort of standard pipeline idea, T1, T2, T3, T4, I'm sure you're familiar with, works with the idea of moving from bench science or clinical trial, which is an efficacy level work, to effectiveness work, looking at general populations, to working with scale up throughout a system, and finally to T4 with roll up and policy change. The problem is that at least for global mental health, and I'm sure maybe global health people in general here would say that when you're working in many of these settings, you can't ignore the outer context ever. Even at the beginning, you have to start thinking about the politicians. You're a guest in that country. It behooves you to get permission from the higher-ups, especially with the hierarchical community, from the get-go. So it's not as if, like it can often be done here, you find you develop striking data and take it to the politicians. Even if it could ever work that way here, it certainly would not work that way there. You have to have them involved from the beginning, their buy-in from the beginning, or you won't even have access. So this is the model from Gregory Ahrens. It's called EPIS, and it starts with something called exploration. And it includes the outer context and the inner context at every level. So exploration is just talking with people and trying to figure out what resources you have that would be of use and how that might work, both on this outer context level, the politicians guiding and funding keyword things, and then the inner context, the hospital or clinic or a collection of clinics that you want to work in. And then the adoption decision preparation phase, where you're thinking about how can we do this in a way that will not cause workflow problems, for example, within the clinic, and what type of treatment should we institute, and then talking at the same time with the policy leaders, if we could do this here, would it work in a bigger way? And then the active implementation phase, where you're actually instituting it, and you're keeping everyone involved on the outer context and the inner context. Finally, the sustainment phase, where you're cultivating local leadership on the outer context, in the politics, in the funding, as well as in the clinic, in the inner context. So I'll show you an example of how we're trying to use a model, something like that, in our work in Kenya right now. We're using what's called an effectiveness implementation hybrid design, and I'm looking at a scalable evidence-based mental health treatment for HIV-positive women affected by gender-based violence in FACES in Kisumu. FACES is the Family AIDS Care Education Services Program. PI here is Craig Cohen, and in Kenya is Elizabeth Bakusi. And this is supported by my K Award, and a supplement was also supported by Hellman Award and a UC Women's Health and Empowerment Grant. So this is just a thumbnail sketch. These are relative prevalences. They're not absolute prevalences, but I just wanted to give you a sense of why this topic is where I'm focusing. So if you looked at the prevalence of depression and trauma-related disorders, which are the two most common mental disorders among HIV-positive populations, if you looked at those in the general population and you assigned them a prevalence of about 1, there. In people living with HIV, that's the PLWH, you would see prevalence of about 2 to 3, so double to triple the times of the general population. But if you look at HIV positive women, you'll see about 5 times the general population. So these are relative prevalences. So suffice to say, HIV positive women have very high rates of depression and PTSD. Why? Well, HIV is associated with violent victimization of women all over the world. That's regardless of epidemic. And survivors of gender-based violence develop PTSD at rates of 60 to 90% and depression at about 50% rates. So bad enough to have depression, PTSD, and HIV, but the problem is that those disorders correlate with decreased adherence to HIV meds, attrition from care, detectable viral loads. In the U.S., fortunately, we've found that treatment of depression and PTSD is associated with increases in ARV adherence, objectively measured ones, and also decreases in viral load. But this is also starting to sound familiar, I'm sure, this research gap, whereas we have 75% of the world's HIV-positive women living in sub-Saharan Africa, there's been almost no treatment research for diagnosed mental illness that includes HIV outcomes for them, despite the fact that GBV is extremely prevalent there, which is where our work comes in. So this is the Family AIDS Care Education and Services Program, Kenya on the left-hand side there, and then a blow-up on the right. This is FACES operates within Nyanza province, except for one site in Nairobi, and specifically in Nyanza province, we're working at the main center, which is the Lumumba Health Center. So we started out doing qualitative research, which is how we've started each one of these chapters of work in various sites. And that's the exploration phase. You go in, in my opinion, best way to start is as a student, as a very humble student, right? So you walk in and see, there are all these statistics, and we've heard from collaborators and people in charge of the clinic that there are some mental health problems potentially. We just want to learn more about it and see if there's any way that we could be of use. So we ask questions like, what type of violence is experienced, or is there violence against HIV-positive women? If so, what type? What types of emotional problems? Does it have any impact on their HIV health? What are their coping methods? Do they think that they want mental health care? If they do, what type would they like? And so what we found is that, universally people were reporting extremely high rates of violence against women. I can talk about that in more detail, but primarily related to a scapegoating of women for bringing HIV into the family. And that's, interestingly, related to policies national policies that require that pregnant women be tested for HIV, which often means that women discover their HIV status before their partner does. And then they are therefore blamed for bringing HIV into the family, even though it could have been the reverse scenario. So they're scapegoated and then often kicked out of the home. Their finances are cut. They are, physically, emotionally, and often sexually abused. And emotional problems that they reported were depression and then lots of symptoms that sounded like stress disorder or trauma disorder. They did notice in this qualitative study that there was an impact on ARV adherence, and they told us that they used coping skills by social support, leaning on one another. They unanimously wanted mental health care, and they wanted something quite straightforward and simple. They wanted some counseling inside the HIV clinic. They wanted it one-on-one. They wanted it, most of them, weekly, which was a very humble request and easy for us to respond to. So we took that data, we thought about it with the clinic, with team members, etc., and we decided we needed to use this effectiveness implementation hybrid design, which is exactly what it sounds like. It's a combination of effectiveness study design with implementation design. There are 3 types. Type 1 emphasizes the effectiveness, the clinical outcomes of the individual. Type 2 is a sort of evenly balanced weight on effectiveness and implementation outcomes, and then type 3 has more weight on implementation outcomes. We use type 1 in order to be conservative ethically to make sure that this treatment worked for HIV-positive women exposed to gender-based violence. This was the first study that's using IPT to treat PTSD in sub-Saharan Africa. It's certainly been used in many other settings in sub-Saharan Africa and in many other of our studies, but this is the first study where we've diagnosed PTSD. Our other studies we've used symptom measures and cutoffs, and that hasn't been done by other teams either. So we wanted to make sure that this vulnerable population we were really attending to their clinical outcomes as a first step. And we decided to use something called interpersonal psychotherapy, which decided to use interpersonal psychotherapy to treat depression and trauma-related disorders, and we decided to deliver it using local personnel without advanced training, which is what we had done in other places, to deliver it inside the walls of the HIV clinic and prioritize involvement of people who were already peripherally or even centrally, if they had extra time, working at FACES. We used a lot of the ARV adherence team members because they happened to be the ones that knew a lot about the psychosocial circumstances of people. People get referred to them when they're not taking their meds, right? So that's when you learn from those people. I couldn't take my meds because I got thrown out of my house last night, so, for example. So you learn what's going on in their life. We also prioritized measurement of things that would be of interest to implementation, people that would be key for implementation. For example, our HIV care providers. So we targeted measuring adherence, measuring viral load, be interested in that medically anyway, and of course measuring economics. So how much does this cost? What's the cost-benefit analysis, which I think is actually critical going beyond cost effectiveness for mental health. So what is IPT? Very briefly, IPT in the world of mental health is as well known as cognitive behavioral therapy is in the popular press. It's a very well-known evidence-based treatment originally developed by Clearman and Weissman for depression. Has the best results in the only face-to-face RCT for depressed HIV-positive patients, and was recently proven non-inferior to traditional exposure-based therapy for PTSD. And I can, again, tell you more about that if you'd like to know. IPT strategizes by intervening in the social support of an individual and conceptualizing the emotional distress as one of 3 specific things: a conflict, a transition, or a loss, and then uses a specific strategy to work through it. You meet with people once a week for an hour for 12 sessions, and we have a history of training people without prior training, even prior health training at all, to do this quite well. Typically what we use in our training we lean on pilot cases, and we train people very carefully, and then we measure their adherence to the IPT protocol. Those people who start scoring in the 8s and 9s are the ones that we allow to move on to taking clinical trial patients. Most people can move on. There are some people who require 2 or 3 patients before they're ready. So putting this into the EPIS context, that exploration phase, so our mental health care needs assessment that's been published, the preparation stage, the adaptation of the IPT, the selection of the study design, that's in submission right now, and that corresponds to the preparation adaptation phase of the EPIS model. The implementation phase is where we are now. We have our clinical outcomes and our implementation outcomes, which I'll discuss with you in a moment, and we currently have enrolled over 220, and then we're already working on the sustainment piece. We're submitting with the current PEPFAR round to try to integrate mental health care across HIV FACES clinics in the Nyanza province. So the MIND study cores, clinically we're looking, of course, at depression and PTSD diagnostically, but also in terms of symptoms. That allows you to see a yes or no, they have PTSD or not, and also if they still have PTSD, are their symptoms better or worse, for example, or depression. The interpersonal core, we're looking at re-victimization with these survivors and their other social adjustment. We're looking at disability and quality of life. We're partnering with Dr. Anna Claire Meyer in neurology, who used to be here, is now at Yale, and she's a neurologist who normed a neurocognitive battery for this specific clinic. And we're partnered with her because there are a couple of scientific hypotheses we want to look at. Depression, PTSD, and HIV all affect cognition. And we're not sure if we treat depression and PTSD whether or not cognition will improve, and if so, how much, because all of those things affect it. Of course, we want it to improve because we think that that will be correlated with perhaps better adherence to medication. Could also be correlated in the PTSD models with better assessment of threat and lower risk of re-victimization. And we have so we're doing a very robust, that's what our supplement is for, neurocognitive assessment at 4 different time points across our study. We have the HIV core, we're doing the viral load assessments and also the self-report of adherence. Implementation-wise, we have our qualitative core, which include exit interviews with the participants and therapists, but also with the clinic staff, local community, and health leaders. Our economics core, where we're partnered with Harsha Thermathy, works with the search study. And he has an instrument that he developed which is really key for women in particular that can measure both formal and informal economic income. Informal meaning things like growing vegetables and selling them, which is rarely captured by a typical traditional economic measure. And it's important for seeing how people are doing economically, especially at this population. IPT fidelity core, the adherence, so monitoring how people are adhering to IPT. We do that through our own adherence measures, and then we also use a procedure of taking a random 20% and having them independently evaluated. And then we have a program for our implementation personnel core. We have an implementation officer whose job is to try to think carefully as the MIND study goes on about what we can do differently and who we can contact to make our findings and our process best match what is needed within the clinic and best integrated with the clinic. We also have a local therapist who I'm training to do independent weekly supervision there on site. So the assessment schedule is straightforward. We'll have about 300 enrolled, randomized to IPT plus treatment as usual or treatment as usual alone. Measure everything at baseline, and at 12 weeks repeat everything except the trauma history questionnaire. Again, same thing at 24 and 36 weeks. At 12 weeks, the treatment as usual group is offered IPT. In our experience, most people do elect to receive it, and then they receive that treatment in the subsequent 12 weeks. So everyone gets treated, and then we follow up through 36 weeks. So just to take a step back for a moment, looking at what has happened with global mental health here at UCSF, I got my Birch Award, the Women's Health Career Award, back in 2011 with Paul's help connecting with the HIV community, and had Monica Gandhi as a great mentor along with Paul, and then connected with Craig Cohen as the site for that, and AIDS Free World as a real inspiration. Eric Gooseby, of course, joined more recently, and he's been just a wonderful mentor for me in terms of thinking how to apply these lessons in a much bigger, broader way and benefit population health. In neurology, working with Anna Claire Myers, I'm also working with Victor Valcourt on the Africa study. Cost analyses, Jim Kahn's been great. Harsha has been instrumental, the Geekon community in general. And then community-based strategies, we're now submitting to partner with Search and Diane Havler to try to see how this could be integrated with a community health screening campaign, just as they've done with HIV. HIV, there's no mystery about why I think mental health and HIV go so well together. Their stories, in my opinion, could be seen as quite parallel. So 20 years ago or so, HIV was a highly stigmatized disease that was most prevalent in low and middle income countries, but most of the treatment resources were in high income countries. So a very similar situation to what we have with mental health. And using those clinics is a nice way to access people who are already willing to go to one place with a stigmatized disease. You can treat another one at the same location. It's a safe place for fearsome diseases. And I think it's a good strategy. It's also something where people have to come back monthly to get their HIV care, as opposed to primary care clinics in many of these settings, which are used more like urgent care. If you have a broken leg, you might show up, but that's not really when you want to get treated for depression. So we've had just a huge growth in terms of our collaboration. I think what sets UCSF apart is our ability in global mental health to synthesize and work across disciplines, as well as our huge strengths in implementation science, from Eric to Diane and everything in between. And then wonderful set of mentees. This is much larger number now in terms of the mentees, interested mentees that we have from psychiatry, nursing, medicine, public health, pre-med, master's students, and from many different institutions. It really just underscores for me, just like that graph, we see this huge, we've known about mental health problems in low and middle income countries since 1990, but there's really only been a burgeoning of publications and funding in the past 5 years. And I think that the rapid recent growth of our mentees underscores the same thing, that this is a really exciting field. There's a lot of opportunity, a ton of valuable, important work to be done. And with that, I will finish up and take questions.